Okay, uterine abnormalities. So, I'm going to see what your opinion is of uterine abnormalities and also show some very recent information. So a paper that we've just had accepted last week. So I've actually presented it last week somewhere else, so you're the second people to see it. Unless you're watching the advanced gynae ultrasound course live streaming from the college. I know someone has because they came and spoke to me this morning. So we did a gynae ultrasound meeting in London 2 weekends ago, and I presented some of this data there. So another nice facility that hopefully you'll see through ISUOG in the coming months and next years, that you can actually attend a conference without leaving your home. Someone actually typed in they were watching from in their pajamas, which I thought was fantastic. So, although it was quite late in the morning. Okay, uterine abnormalities. A big problem in India? Do you think do they affect fertility? Miscarriage? Preterm labor? Do you do lots of operations for uterine abnormalities? Metroplasty? Okay. So the septate uterus, are you chopping the septums out? Are you operating? Okay. An arcuate uterus, is it a problem or? No. Interesting. Okay. So basically the consensus is that the arcuate uterus isn't really important and you should operate on the rest because they affect fertility, miscarriage, and that's sort of what, I know someone's shaking their head, but that's what most people said. I think that's what the general consensus worldwide. Everyone I ask the same question, same answer. So let's see if you're right. Okay, now, hopefully, well, one thing I would say, the AV equipment in India is better than any other country, I think. So this image normally isn't so clear. Is this a normal uterus? I can't. It is a bit dull, partly that. Okay. Gain. Okay. What do you think? Show you more of the uterus. Okay. I give you a second chance. I appreciate the gain. It's not bright, but I'm partly that's the. Just there. Normal, septate, arcuate. Hands up for arcuate. Oh, I like that answer. Hands up for septate. You want to we saw the transverse, it showed the, and hands up for you need a 3D. Now, here's the 3D image. So again, we see how quickly you can do it. You will see, and I do apologize, the quality isn't that clear, but if you look at the coronal plane, what's the diagnosis? Arcuate uterus. Well done. So once you're quite right, you should not be making a diagnosis in 2D. But once you obtain this image, you can see in the coronal plane, it is arcuate. And I'll explain to you why it's arcuate and why it's not normal and why it's not septate. But essentially, I'll show you the classification in a minute, but you can see that we have an indentation of the upper contour of the endometrium, so it's not normal. But that indentation is obtuse. It doesn't achieve acute angle. You don't have a sharp area, so it is an arcuate uterus. Is this important? No. How many ladies in the audience have an arcuate uterus? I know. So 4 to 6% of you. We'll talk about how many of you have polycystic ovaries after break. That's even worse. Okay, so now these are not dynamic images, but I just want to show you again the concept of a multiplanar view, that we can see our longitudinal and our transverse images here. And yes, I should be able to move them to show you, but what do you think about this uterus? Can't really say, can you? And I know if I showed you the transverse plane, you're quite right. Diagnosis? So you don't need a dynamic image. You need a coronal plane showing the interstitial portions of the tube. You must align the uterus. Arcuate uterus, quite right. And we agree, or so far we're saying this probably isn't important. Nice junctional zone, did you see there again? This one, again, if I show the subseptate. I heard an arcuate. Anyone for septate? Well done. You're definitely doing better than most people. Why is it subseptate and not septate? Absolutely, so that it does not extend to the cervix. Why is it not bicornu at all? Brilliant. Okay, we should just have coffee now. So you're quite right. Look how nicely you can see in the C plane. You don't need the rendered image, but you can see that we have a normal fundus. So you must talk about external and internal contour. It's really important. I promise you, most people get these wrong. Now, typically when you see this image, you see that transverse view, and we hear, the commonest thing we hear is bicornuate uterus. I'm very pleased to see people shaking, but we see there is this response that when you see in 2D two separate cavities that people say bicornuate. I've seen it all the time. You can't say is the answer. Oh. So I think the answer is wait till you see the 3D image. Look at the external contour. Do you see there's a little indentation? But it's only little. How big does the indentation have to be? How do you know all this? Absolutely. Okay, so that's septate all the way down. And it's obvious what's going to happen. Again, just be careful. Just because these cavities are far apart, you don't make the diagnosis till you've seen the coronal view. Now here, I think, well, didelphus maybe, but what you need to look at here, we have a big gap, but we do have the indentation. Now, actually, if we're going to be really strict, that probably isn't a centimetre, is it? So I think we should argue this is probably a septate uterus, but I've called it bicornuate. Really, it should be indented. Now, how common is the bicornuate uterus? Because according to the literature, it's about 1 in 200. According to my practice, I've seen 1 in 13 years. And people that come and work with me, when they've gone back to work in other places, yeah, I know I'm much younger than I look, but one lady, so Emily Lam, who worked with me in Hong Kong, she went back and she found this in about the first 3 weeks of working. And she found this, okay? So we have our big typical one and we have our 1 centimetre. So she was really excited. Apologies. Now, she's not found another one. Now, if you use the classification systems that we're describing, so a true indentation of 1 centimetre, they're actually not that common. And what I think we find is the literature, there are many people or many diagnoses of bicornuate, which in many cases actually aren't. So in fact, to see the defect is not, in our experience, is not that common. HSG cannot be used at all. Here you go. Unicornuate, very difficult to see. And one thing again, these unicornuate uteri do not appear that often in the literature. If you look at the literature, arcuate, the classic one is septate. We see a lot of bicornuate, very few arcuate, very few unicornuate uterus. And the reason is exactly what you've said. People make the diagnosis on 2D and HSG and hysteroscopy. And if you look at the literature for series that have come from hysteroscopy diagnosis, how common is the arcuate uterus? I can tell you in many cases the answer is 0. Because when you fill a cavity up with saline, you can't see it. So you have to be very careful in looking at the literature, looking at prevalence rates. Now we have 3D, you need to rethink because you can't make a mistake. Patients can make the diagnosis. True. 3D is the new 2D. Now, just as another example, look at this. So here you can see an abnormality in 2D. And I appreciate the video is quite quick, but I'm going to show you the 3D view, and then I'll let the 2D run, and you will agree with me. It's still easy to make the diagnosis in 2D, but you've got to know what you're looking for. Do you see? I heard a banana there. So what you can see, do you see the lower part of the endometrium? Almost like a teardrop. Diagnosis? Oh, it says, doesn't it? It says unicorn. That makes it too easy. Now, look at the 3D image. I promise you it's the same. It's exactly the same patient. And if you look again at the 2D image, you can see the lower half of the endometrium is completely missing. Completely missing. Now, it's easy to miss that when you're doing a 2D scan. But what I find is now I know what a unicornuate uterus looks like in 3D, I can identify it in 2D, which comes back to what I said this morning. I think 3D helps you learn to observe 3D in 2D. Because again, we're trying to do a 2D image to create a 3D image. So that's unicornuate. Notice how thin the endometrium is. Now, I don't want you to go away with the idea that anyone with a thin endometrium may have a unicornuate uterus, but just think twice about that, because there are some people that it does appear to be thin. And the one that we're missing is this one. And again, you can't see it so clearly, but just for the MRI fans out there, you don't necessarily need an MRI to make this diagnosis, particularly now that we have wide angle. you can actually get the whole uterus and lower cervix in some cases. Increased risk of erectile stimulation. It's linear. So 32 is worse than 22, 42 worse again. But 22 is an interesting number because if you think about it, if you have 23 follicles, you must have polycystic ovaries. Because if you have 11 and 11, so you've just missed the criteria, that adds up to 22. But if you've got 23, one must have 12. So having been very much against the Rotterdam criteria, and we've written quite a few papers saying we really think the value is too low, in our own experience in our IVF unit, if you use that value, it gets you to roughly around 22, which seems to be, or seems to have clinical relevance. So it's very interesting that it works in our hands. Just want to leave you with this about the idea of, I mentioned earlier about blood flow and function. I think it is important, but it's hard to do. So I won't show you the data or the details, but we've looked at blood flow and other measures, and we found that if you look at women with polycystic ovaries compared to controls, there's no difference. But if you look at the phenotype, we found that in women that were hyperandrogenic, they had abnormal blood flow. And in fact, we've published this 2 separate papers now. We found that endometrial blood flow was reduced, but ovarian blood flow was increased, but only if they're hyperandrogenic. It didn't matter about weight, and it didn't matter about the cycle regularity. It was all about hyperandrogenism. So there's a link between the ultrasound features and the phenotype. And this is another example. So another group here from Canada has shown something similar, that if you actually, again, look at amenorrheic women this time, not hyperandrogenic, but amenorrheic women, they showed a difference with regard to insulin resistance. So there is definitely a relationship between what we see and metabolic function, that's the key at the end of the day. So if we think overall, it is very important that you remember that the ultrasound features do not mean you have the syndrome. You're just defining a polycystic ovary. So unfortunately, the minute it becomes 12, it's polycystic. 11 is normal, 12 isn't. It doesn't make any physiological sense. But you can use that value because it does have clinical relevance in terms of prediction of OHSS, but also it means that you in India will be talking about the same ovary that I'm talking about in Nottingham. Now, I think what's important is I'd rather know what the volume of the ovary is and the number of follicles than whether it's polycystic or not. Because an ovary with 12 follicles is very different to one with 32. So I think having an absolute cutoff doesn't make any sense to me. But the Rotterdam consensus does allow standardization and conformity, and I think that's really, really important. I think the current diagnosis, there's a huge limitation. What we're really interested in is, can we use ultrasound to help us look at the clinical phenotypes and the metabolic consequences? And I don't think we can. But I'll leave you with a thought. So if you're in your laboratory and you see someone, you have a thyroid function test come back, slightly raised thyroxine, or slightly low thyroxine or raised TSH, is that woman, or does she have thyroid disease? If you have a prolactin of 880, do you need to treat it? Or if you've got a cortisol, free cortisol in the morning, it's slightly raised, does that woman have Cushing's syndrome and need treatment? You would never treat on the basis of a test, ever. And you wouldn't make a diagnosis. What you would do is you'd look at the clinical features. And I think for me, that's the big thing that's missing with PCO, is that we have to move away, because we're all interested in ultrasound. It's just a very small part. And you must interpret that picture against the clinical phenotype, just as you do with every other endocrine disease. And remember, Rotterdam has at the bottom, you know the small print, okay, in italics? It's a diagnosis of exclusion, that you've excluded other endocrine diseases. So remember that. So I think, I don't think you should say just because you have a certain number of follicles. And the reason why I've put N here is you're going to see very soon that this may change from 12 to a higher figure. I can't tell you what it is, because the data's not been published yet and it's not mine. But we are going to see a change in there. And I think the other thing we're going to see is the introduction of AMH. Now, what I'd like to see is that we don't suddenly say a follicle count of X or an AMH of X equals polycystic ovaries. It does not make sense that at a certain level you're normal and the next level you're not. It's an endocrine disease, it's a spectrum. And I think that's my take-home message. Thank you very much. And he's been working with me now. He did his PhD with me, and he's now, he worked as a lecturer, then a sub-spec trainee, and then we got him a job. So he's a senior lecturer with me. And he's done very well. Done a lot of work on antral follicles, which we'll talk about. And then Jeanette, who's a scanner, she did all the work, really. When we're traveling around the world, she's been doing all the scanning and all the measurements. She's gone blind now. She hasn't really, but she's retired, unfortunately. hysteroscopy, laparoscopy combinations, etc., is that they do not have 100% specificity. So in terms of specificity, we're saying you can scan somebody and you can say their uterus is normal or not. This is where 3D is really good. It's not just good for identifying an abnormality and its subclassification. 3D is also really good to say you have a normal uterus. And I think that's really important. Because the problem you're going to find is that when you start playing with 3D, you can get very confused. Now, if you add OmniView to a slightly unorganized coronal plane, you will end up making a uterus abnormal. So be very careful. So go back to what I said this morning, standardize your view, make sure you see the interstitium, and then make a diagnosis. But be careful, otherwise you might get... This isn't from the local game reserve, don't worry. So the American classification system, I think we could argue is redundant. If you look at this now, look at their diagnosis of arcuate uterus. It's not what we would agree is an arcuate uterus. Do you see the indentation? This is what I strongly recommend you use. I think this is fantastic. So this is from Rayhan Salim, who was Davo Jurkovic's research fellow. It's a really nice system, and it lends itself because it's based on 3D, which I think we all would agree now is the gold standard. I mean, no argument MRI would work there, but 3D is easy to use and we all have it. So we've talked about the view. You need the coronal view with the interstitial parts of the tube. And then what we need to look at, first thing, look at the external contour of the uterus. If it's normal, okay, then we know it's going to have to be normal arcuate septate or subseptate. It's only when it becomes abnormal with an indentation of more than 1 centimeter that it's bicornuate or unicornuate. So look at the external contour first of all and work out how deep the defect is. And to do that, you also need to do what you can see here, work out where the upper aspect is and measure the defect as I showed you on that image from Hong Kong that Emily sent me. Next thing you need to do is look at the internal contour. Now, if it's straight, you have a normal uterus. If it's indented, but it's obtuse, then it's arcuate. If it's acute, then it's either septate or subseptate. If it extends to the cervix, it's septate. If it doesn't, it's subseptate. I think if you use that algorithm, you can't go wrong. Everybody would agree. We'd all have the same diagnosis. Now, it was very interesting. Honestly, I'm not trying to flatter you, but you, as an audience, are the only people that have got most of those right. People make all sorts of mistakes and make different diagnoses, say arcuate, septate, and subseptate. So it's actually very encouraging to hear that. But I think if we use this system, and I believe probably a lot of you were from your answers, I think we'll get close to us all agreeing. And until we all have 100% agreement, the literature is confusing. Because if we look back and say 20 women had arcuate uterus, 30 had a septate, did they really have a septate uterus? Or was it arcuate? Were the arcuates diagnosed as normal? Were the bicornuate septate? So I think at the moment, unless you look at 3D studies, who knows what's going on? This, until recently, I think is probably the best piece of work from T.C. Lee's group and Sotiris Saravelis, who does very nice systematic reviews, did a review back in 2008 looking at the prevalence. So just how common are uterine abnormalities? Doesn't say what happens to patients with them, but how common are they? Now, what you want to look at in the audience is the class 3. So class 1 diagnosis was accurate. They divided it to A and B. A was accurate, and you could subclassify. So you could identify an abnormality and say what it was. Class 1B, you could say the uterus is abnormal, but you weren't so sure what it was. I think we would argue now you need class 1A. You need to know what it is. But look what's in class 3, tests of uncertain diagnosis. One was examination at cesarean section. I think we'd all agree that doesn't really help. MRI. So for you radiologists, this is what they thought. MRI is not very good, or of uncertain diagnosis. Well, we disagreed with that. So we have just repeated this study. We've looked solely at class 1A, but we've also included MRI. So we've repeated this analysis of what we now feel are more precise tests. And this has just been accepted, as I mentioned. This is just coming out in Human Reproduction Update. So it's an update of that review. Now, we looked at 6,266 citations. We eventually ended up with 94 papers. And it's a theme that we see often in gynecology, that if you look at a lot of the studies, many aren't worthy of looking at in more detail. So you have to be very careful. And I'm going to mention that at the very end. I don't want you to go away with the idea that if you see a systematic review, that it's written in stone. And a lot of people do that. Systematic review, that's the answer. Systematic reviews are based on collections of studies because we don't have the definitive study. If you have a large prospective randomized controlled trial, then that's the answer. But we don't, which is why we do systematic reviews. It doesn't mean the answer is absolutely correct. So just be a little bit hesitant before you believe everything that you read. Now, this is our results. It's a confusing table. Unfortunately, there's no way around it. But just to make it simple for you, if we look at this top bar, this is an unselected population. And we can see that the prevalence of abnormalities is around 5%. So 5% of people, normal, everyday people, have a uterine abnormality. The commonest, by far, is the arcuate uterus. And then what we did is we grouped people into what are called canalization defects. So septate and subseptate uteri. The reason why we put them together is we weren't confident enough that people had diagnosed them correctly or used the classification that we now use. And then we put together bicornuate, unicorn, and diadelphus as unification defects because, again, we were a little uncertain. There's still a great deal of limitation in this because some of the septums may have been bicornuates and vice versa, as we've said. What we then looked at, if you look at the different groups, we didn't choose to look at women with infertility, women having IVF, women with miscarriage, and women both with infertility and miscarriage. But we had to because this is what's in the literature. I would like to stand before you and present today the prevalence in women with 1 miscarriage, 2 miscarriage, 3 miscarriage, 1 miscarriage, normal baby, another miscarriage. But we can't because it doesn't exist. That literature does not exist. So we are forced to look at just these groups. So first of all, that's a big limitation. And if we look across from arcuate, canalization to unification, what you can see is the grey areas are significantly increased. And I don't think it's worth looking at these in precise detail, but what you can see is as we look at these high-risk groups, the incidence of all uterine abnormalities is increased. So that's interesting. So there is a suggestion that these things are important. And the problem is, in this situation, is we're talking about how common are they. But if you then scan somebody and you say you have a septate uterus or you have an arcuate uterus and the patient says to you, what does it mean? What I've just shown you doesn't help. All you're saying is they're common. You just say, well, we know that women who are infertile or women with miscarriage are more likely to have a uterine abnormality. But if she says, so what? What's going to happen to me? You can't answer, which is why you have to do another review, which is called an association review. Now, this we've just sent in now for someone to the BMJ to look at. Now, this is taking women with the abnormality and following them prospectively. So you can see we've got the groups across the top, and then we have conception, miscarriage in the first trimester, miscarriage in the second trimester, preterm birth, and malpresentation. The arcuate uterus, which we all said is a benign finding, if you look here, you can see it's significantly increased, double the chance of second trimester miscarriage. Several studies have shown that. So interesting. So maybe it's not so benign. Canalization defects, we can see there seems to be a reduction in conception rates, an increase in miscarriage in the first trimester, but not second, and preterm birth, doubling of preterm birth. And in bicornuate, very similar, again, an increase in miscarriage rates and preterm birth. And we see similar things with diadelphus and unicornuate uteri. But again, I don't want you to go away with a message this is precise data. It's not. But it's just giving you a suggestion that actually these things are important prospectively. Just to show you that as a forest plot, because I think we understand these more, if we look at just 2 groups, the arcuate uterus and the septate and subseptate uteri, we can see here, first of all, conception. Arcuate uterus, no effect. Septums seem to reduce the chance of you getting pregnant. If you then look at miscarriage in the first trimester, no effect of arcuate uterus, but the septate uteri increase, they double the chance of first trimester loss. Second trimester miscarriage, this is the really interesting group where our review and several studies have suggested that the arcuate uterus might increase later pregnancy loss, but not earlier. Whereas the septums at this stage, there doesn't seem to be such a high rate. Maybe that's because the patients have already miscarried. And if we look at preterm labor, which I think we'd argue is the most important outcome, because we know it's the #1 association of perinatal morbidity and mortality, again, arcuate uterus doesn't reach significance, mainly because of that end study there. Otherwise, it probably would have done. But then if we look at the canalization defects, again, we have roughly a doubling in the chance of preterm delivery, which is a big concern. Now, before I talk about the treatment of them, just to show you some work from our group, we first of all looked at how common these uterine abnormalities were in our own IVF population, but we've now followed it up and we've looked at their outcome for live birth, because that's what we're really interested in. And what I want to show you is, having just said that these abnormalities may be important, is let's actually look at some real data from a unit where we're using 3D, we've got an accurate diagnosis, we follow them prospectively. So we've got 822 subjects that we followed right to term birth. And what I want you to show, just to summarize, 414 got pregnant, shows you our very high success rates in nurture. We found no difference at all in conception rates. So people got pregnant whether they had an abnormal uterus or a normal uterus. No difference at all. And there was no difference in miscarriage rates, and there was no difference in live birth rates. So despite, as I mentioned at the start, you have to be careful when you look at systematic reviews. And yes, maybe uterine abnormalities are important. And we have small numbers here still, and that's why we need systematic reviews. But in our experience, it didn't have any impact on our own patients, which is interesting. So what does it all mean? I don't know, unfortunately. But if we say that uterine abnormalities are important, why would they cause a problem? We have this hypothesis that it's blood flow, that you have either, I've heard both extremes, that the septum is too vascular, and I've heard that the septum is avascular. I've heard both. I can't believe it myself. A septum is normal myometrum. It's vascular. If you put Doppler on, you will see a signal. But it is a hypothesis, and maybe it's right, maybe it isn't. So the embryo implants on a septum, it then you don't get normal placentation. That might be right. Doesn't explain arcuate uterus. This is our theory. We think it might be to do with stretch. It might be a smooth muscle myometrial problem. And the reason why, if we first of all show here, we have a nice image of some fibroids. Now, if you look at this review, this is one review. There are now 3 systematic reviews of the effect of fibroids on reproductive performance. If you look at fibroids that do not affect the cavity, small mural fibroids, the evidence is from all 3 reviews, they increase the risk of miscarriage. So a fibroid that doesn't affect the cavity still increases miscarriage rates and reduces live birth. So why would a fibroid not affecting the cavity do that? It's the same question as uterine abnormalities. Well, this is the reason why I believe. So here we can see beauty of 3D. You see the 2D image, it's poor, you can't really make a diagnosis. So one thing I would say, whilst I agree that you must get the best 2D image you can make a 2D image better on 3D. But you have to play with it and render it. And you can see here, we've gone from not very clear in 2D, look at the render view. Now, can you imagine what this would look like hysteroscopically? So we have a subtle fundal indentation, we have a subseptate uterus, and we have a big submucosal fibroid. Now, I just want to show you why we should call it virtual hysteroscopy. So if you look here, this is the uterus. It's identical. Our coronal view, that is an improved image on our 2D view, it matches exactly what we see. Now, second thing, look at the anterior-posterior diameter of the uterus. I want you to look at how wide the front to the back of the uterus is. You may not notice it at the moment, but what you're going to see is as we resect the septum, I want you to see how the cavity expands. So just note to start with, I'll show you one of the Blue Peter videos of what this looked like at the end. But you can see here, if we move back, that there's actually quite a narrow uterus front to back. Do you see? So we feel this septum is almost acting like an elastic band. It's pulling the uterus together. Now, one thing I did ask you is, do you operate on them? And you now realize that we do as well. And what I was going to ask you is, where's your evidence for that? Because there's a Cochrane review just about to come out. There are no randomized studies of metroplasty, just being published by Ben Moll's group. So at the moment, you are practicing an evidence-based medicine, but so do we. So we resect these things as well, but we have not got a properly prospective randomized study. So I think it's very important that you tell your patients we don't actually know that this is beneficial, and we don't know this is not detrimental. But what you can see here, very easy, as the septum's resected, can you see that the uterus is expanding? Now, should you use electrodiathermy? I think we should be probably using scissors for this, but do you see how it's already increasing? If we look at the end, so this is the end product, and you will see that it's the same uterus because you can see the submucosal fibroid. So as we move up the canal, look how much bigger the uterus is. It's expanded almost threefold. So our theory is that possibly uterine abnormalities may affect reproductive outcome because they stop uterine expansion. And it could be the same reason why some fibroids also may have an impact. Is it something to do with myometrial stretch? It's only a theory. It might be completely wrong, but it's sort of logical, and I like easy explanations. So we're going to run with this one for the time being. And I think what we do need, we need a proper prospective study. We need to randomize people to resection or not, and then look at the outcome. And it's something we're trying to do. We're doing a study called Septum, which you have to have a good name to get money these days. So Septum is a systematic evaluation of the prevalence and treatment of uterine malformations. There is a study called Trust, which is ongoing in Holland already by Ben Moll's group, and we're working with them. They've already started. So you will find out the evidence soon. So I think, to conclude, 3D is definitely the standard. Use the classification by Salium. I think it's really nice. It just works. Rarely do you get such a clear classification that I think we can all agree on. Do uterine abnormalities have an impact? It's hard to say. I think the answer is they probably do. Is there an effective treatment? We do not know. And I think we have to be honest about that. And is the treatment safe? We don't know. And I'll leave you, not with this thought, but I want to leave you with this thought. So again, just to show you why you have to be careful about science. Now, you see these equations all the time. Typically, they come from groups looking at early pregnancy. Progesterone times 0.3 multiplied by pi HCG equals viable pregnancy at 11 weeks. And how on earth you do that? But I found this equation the other day. I'm really disappointed because it's in the Hindu Times. And because I made these slides yesterday, you can see 18th of June. I should have put the Hindu Times in, but it's silly enough. So from the male, so we have TB, 2 minutes BT plus C. What is that all about? Right. It's interesting. It is actually making the perfect cup of tea, which I believe you do very well. And someone had a tea timer the other day. So TB is actually tea bag, water at 100 degrees C. You then have 2 minutes brewing time, plus C, which is milk, 10 mils, and then 6 minutes brewing time equals the perfect cup of tea. But just be careful, just to show you how people misinterpret data. So they've said the scientists have got it down to a T. 6 minutes, you must drink it after 6 minutes, and you brew it for 2 minutes. But if you actually read it carefully, they also say after 17 minutes and 30 seconds, tea falls below its best. But if you actually look at what they did say, they've misinterpreted it completely. They said you put your tea bag in for 2 minutes, then you take it out, then you add the milk, and then it's 6 minutes. So it's not 6 minutes brewing time. So they've completely misinterpreted their own data. So be careful is the take-home message. Thank you very much.